42.
Okay.
He has a history of recurrent acute pancreatitis. So he had MRCP done. I think he had at least 5 episodes of acute pancreatitis.
Yes.
He had an MRCP done that showed pancreas divisum and some features of chronic pancreatitis. So he was referred here to perform pain control with a steroid injection.
Yes.
In the plexus.
Thank you, Alberto, for the
memory.
The good memory. With the good between the atrium and also pulmonary artery. This is subcanal window. Then I have to pull back a little bit, talk anti-clockwise. You see the trachea. This is the ladder, and this is the almost the air. And then I have to anti-clockwise again to pull back. You see the Mickey Mouse appearance with the between the pulmonary artery and also the aorta, and you see there's a lymph node there. So is it significant, Alberto, or not? So
because he has a central hyperechoic spot, so this is a benign. Maybe somebody was a smoker.
Okay, so this is a benign lymph node. Usually don't perform any biopsy or FNA. So I have to advance a little bit. As you see, this is a landmark. So the first landmark for AUS here, we have to see the liver. So this is the very wide, the IVC, as you see in the crossing in the liver, very compressible. And once you talk clockwise, you're seeing almost the portal vein there, very clear portal vein, as well with hyperechoic wall. Then more clockwise, you see the aorta. This is the aorta. I have to push in a little bit. I have to keep it in the center to see the landmark. The first landmark will be the celiac trunk, give you 3 main arches. Left gastric, and usually very difficult. And then you have the splenic and hepatic. Then push a little bit, you see it, this is the SMA. So this is under the pancreas. I have to push in a little bit to see the pancreas. This is the pancreas. So what do you think, Alberto, about the pancreas?
It seems subnormal. So it seems there's hyperechoic foci. I don't see the duct, or at least the duct, if the duct is very small. So it's kind of a sausage-like, you see, the duct appears and disappears.
Yes,
so this is
looking for either a chronicity from the recurrent attack of pancreatitis or maybe another etiology. Now, we entertain one of the etiology could be autoimmune pancreatitis.
It's also strange that the chronic pancreatitis, there's no minimal duct dilation, no?
Yes, so exactly, yes. So now there's a lobularities, a large pancreas. If you want to track the pancreas from the body to the tail, I have to pull back and then clockwise.
So, great demonstration. Yeah. Thank you very much for this. So, what is your strategy or for this?
The head of the pancreas is different from the body and tail, so it's a little bit less, there's less sign of a chronic pancreatitis or lobularity as compared. So, this patient is younger. There's no autoimmune diseases associated, but one of the causes of recurrent acute pancreatitis is autoimmune pancreatitis. And maybe the fact that he has divisum may kind of shift the diagnosis to divisum and not to autoimmune pancreatitis.
Okay.
So are you going to take a look at the papilla?
Yes. So now I'm advancing the scope to the duodenum. To examine the papilla endoscopically, or I have to, depends on the AOS. So I have to either locate the papilla first by the endoscopy, but I think
we have
the
a
AOS
question
sometimes
from
very
Dr.
helpful.
Ahmad. What's the
Once
question?
we see the aorta and then IVC here, you are deep beyond the D2. So I have to go back to see this is the answer process of the pancreas there. You see it? So you know the debate about division. You have a big debate of division. Some of them, they don't believe about it as a real etiology. And some of the authors, they think this is some of the main cause of recurrent attack of pancreatitis.
So he had a sphincterotomy for minor papilla?
With papillotomy. So still now with the EUS findings, I believe with my colleagues here, Alberto, we have to think about autoimmune, or you have to think about this patient resolving acute attack of pancreatitis. So the question to perform FNB for the
Dr. Abid, I would probably vote for fine needle biopsy. I mean, if this patient does not develop chronic pancreatitis yet, so there's maybe something we can do if she has or he has autoimmune pancreatitis. So I'm not sure if everyone agree, but maybe US FNB will be the next, because it is really questionable the association between pancreatic divism and history of recurrent pancreatitis. So sometimes it's not related, it's just coincidence.
So there are a lot of techniques performing the FNB. So the most proven technique is a slow pull technique. Well, so and then the wet technique. Now we have the needle. Okay. Yeah. Yeah. Now.
So
the needle is inside already. So maybe Bart, can help me. Yes.
So Abu Ahmed, you are doing the slow pull technique, or?
Yeah. So this is okay. You have to go and then pull. Right.
Then you told me to go slow. Because
yeah, we can see here the pull is like gradual. So this is the slow pull technique,
but it's true,
which showed as good as the wet suction in biopsy.
Okay. Okay. So try to see what we got. So this is.
So we can switch to the.
Okay.
We can switch the camera to yeah.
But now the data is proven that the rituximab is a treatment of the autoimmune pancreatitis with a good result.
Okay. So Dr. Abid, can we see the sample? Can we have the?
Yes, you have it, Joe. Yeah. It's more. Very small. Yeah. Yeah, without. Yeah. Yeah.
So would that be enough, or you will take another one?
So we'll take another one to make sure about the good specimen.
So what you would choose the technique if the sample, the first sample was not enough? Would you now change to a wet suction or dry suction or without?
Yes, that's a good question. So probably